Okay, we're at the beginning. Welcome everybody, welcome first years to the first dose of lung pathology. What I'm going to talk about today is two things, and we're going to keep it very, very simple and basic. This is an introduction, so I'm assuming you don't know anything about lung. You don't even know what, maybe you know what normal lung looks like, but very minimal background knowledge. So we are going to talk about types of biopsies. So the types of biopsies you see in lung pathology and some non-neoplastic lung. So it will be a very basic introduction to that. And the second thing I want you to learn is some approach to lung cancer therapy. And why I want you to learn this is not because you're going to be treating anybody, is because when you look at biopsies, you should be thinking of how this patient is going to be treated. Right? So for every lung cancer specimen you get, that should be in the back of your mind. What do I need to let them know? What do they need for treatment? How treatment is going to go? Alright, so first part will be about specimen types, and about, this clock isn't working, but 8:30 we'll switch to lung cancer therapy, okay? So I do my lectures with one very simple basic goal in mind, is that you should learn one thing when this lecture is finished that you didn't know before, okay? So this is the one thing you will learn. All of you must know this. So you must be able to look at that on a slide, right? Without the form, without the history, without knowing what the procedure was. You should be able to look at that slide and then look at the microscopic and be able to say what kind of biopsy it is. So from the first year, just raise your hand if you're sure what kind of biopsy this is, just by these findings. Raise your hand. Okay, so 2 people. And let's see if I can call you out. So I won't say your name, but the ones who raised your hand, what kind of biopsy do you think? Meredith, what do you think? And why is that?
Because it's not like core-shaped.
Is there any other kind of biopsy that in the lung that might not be core-shaped? Meredith?
Yes.
Yes? What kind?
I don't know.
Okay. But you're right. So there is another kind of biopsy that might not be core-shaped, but actually you both are right. So if everybody wants to take home one thing from this lecture, right here it is on the first slide. This is a transbronchial biopsy. This is the kind of biopsy among the small ones that you will see the most in lung pathology. Okay? So you should be able to just look at the slide and say, that's a transbronchial. So sometimes the form will be mislabeled, sometimes the clinical procedure might not be available, but you should be able to tell that. And I'll show you why and what the criteria are to tell what a transbronchial biopsy is. So this is part 1 of the lecture. So 3 criteria for a transbronch. It should be small, and small means just like a millimeter or that size, very, very small. Not needle shaped, just like they said. Not needle shaped. So a needle shape would be what kind of biopsy? Transthoracic, right? And what else is it called? Anyone? The transthoracic biopsy that radiologists do with CT guidance, what is it called? It is transthoracic, it is transcutaneous too, but if you say, I got this kind of biopsy, what would you say? What is it shaped like? Yeah, CT guided what? Needle, yes. It's a core needle biopsy. Core needle biopsy, okay? That's almost like the opposite of a transbronchial biopsy, because a transbronchial biopsy is being done by a bronchoscopist who goes through the bronchus and biopsies usually central lesions. A transthoracic biopsy is being done by a radiologist who's using CT guidance to come from the outside and usually sample peripheral lesions. Do you understand that? Yes? Okay. So small, not needle shaped, and here's the crucial thing that separates this from the other kind of small round biopsy, which is that it has alveoli. So if it has alveoli and is small and not needle shaped, it has to be a transbronchial biopsy. There's nothing else it can be. If it does not have alveoli, what kind of biopsy would it be? Endobronchial. So the difference between transbronch and endobronch is, if you're going through a bronchus, let's say this room is a bronchus and I'm the scope, so I'm going in there through the bronchus. Where are the alveoli? Yeah, up there or around, right? So what the transbronch aims to do is it pokes through this and goes into the alveoli and aims to pull out some alveoli from the lung in there. So the biopsy has to be alveolated, right? That's what a transbronch tries to do. And endobronch is not trying to do that. And endobronch is trying to biopsy something right here. So it grabs the lesion pulls out the lesion, and that's an endobronchial biopsy. It's within the bronchus. And the lesion generally is endobronchial or in the wall of the bronchus. So would be in the wall of this room. But if the lesion is in the next room, you need a transbronchial biopsy to get it. Everybody clear on that? So an endobronchial biopsy should not have alveoli in it. If it does, they really were, they made a mistake. They went past what they were trying to do. So an endobronchial biopsy does not have alveoli, and a transbronchial biopsy does have alveoli. And between those three, you've pretty much covered all the small lung biopsies: transbronch, endobronch, and core needle biopsy. And that's what you'll see. So Narendra, you're starting today, you'll see all those three, and I'll ask you once during sign-out what kind of biopsy you see, okay? So it'll be a test. So that's the answer. And when I say small, I mean small like this. Really tiny fragments, and you should be able to tell just by looking at it, but we are dealing with a small biopsy of the lung. And then that's the correct answer. How do they get transbronchial biopsies? They use these forceps. You see, that forceps is grabbing hold of a piece of tissue, lung tissue like that. These are called, it looks like a particular kind of animal. Can anyone guess? Yeah, alligator. So these are called alligator forceps or crocodile. I don't think that called crocodile forceps, but alligator forceps because of their teeth like that. So these big forceps, they can actually grab large pieces of relatively large, for a forceps, pieces of tissue, and then they plop them right there in a bucket of formalin, in a small jar of formalin. So when you get a transbronchial biopsy, you'll get a small jar and small pieces of tissue in there. You have to be careful to grasp it slowly if you're gently if you're grossing it, because if you grab it tight, it'll squish, and then you won't be able to. It'll be all collapsed lung on the histology. So these are your alligator forceps. This is a slide from Dr. Mehta, who's one of our legends here in pulmonary medicine, and he gives a talk on bronchoscopy, or gives these talks all over the world, and he graciously lended me this slide. Basically, what this is what can you do when you do a bronchoscopic procedure. So you can do a transbronchial biopsy, which is up there. You can do a brush. So you can, let's say this is the lesion, you don't necessarily need to grab a piece of it, you could just brush it and then send that to cytology, right? And cytologists will look at that specifically. You can also, so let's keep the same analogy that this is the bronchoscope. So you take the bronchoscope, you go into one of the smallest bronchi and you wedge the bronchoscope in there, right? So it gets stuck in there. And then you can flood the alveoli with fluid. And then that fluid can come back and that becomes the bronchoalveolar lavage, right? So what you're getting in that fluid is the composition of the alveoli that are outside. So you're not worried about the within bronchus stuff there. So that bronchoalveolar lavage fluid, or BAL, is one of the things that a bronchoscopist can do when they're in there trying to assess what's going on in the lung. Is that clear to everyone? Now's your chance to ask questions about this. Any questions so far? Everything clear to everyone? Let's move on. So here is how, when you're actually in the bronchus, that it looks like when you have an alligator forceps. So this forceps is then going to go into the lung and try to grab tissue from there. Okay? And you'll get this kind of a specimen. Now, an endobronchial biopsy is also small, also not needle-shaped because it's not a core needle biopsy, but it does not have alveoli. Clear to everyone? What it should have is pieces of bronchial mucosa, it will have pieces of the lesion, and that's pretty much all it should have. Bronchial wall even, so if it goes deep into the wall, it can grab pieces of cartilage, pieces of the mucosa, epithelium, lesion. Let's say that telephone is the lesion. Ideally, you grab the lesion like that and you have pieces of that in the tissue. That's an endobronchial biopsy. And this is how you take it. Again, you have some kind of a forceps, you grab the lesion and you get it out. Clear to everyone? So back to transbronchial biopsies. One thing the bronchoscopist does is, if you want to get a relatively peripheral abnormality, like something that's located not right next to the bronchus in the center of the lung, but out next to the pleura, one thing they do is they push the forceps right out to where the pleura is located and then pull back a little bit. Now sometimes what happens is, maybe the patient coughs, maybe the location of the pleura is not quite right. Sometimes they actually get fragments of pleura in the endobronchial, in the transbronchial biopsy. So you can actually go peripherally enough to get fragments of pleura, and that's one of the things I ask. And there's pictures of it in my book. You can actually find pieces of pleural tissue with mesothelial cells in transbronchial biopsies, even though you think, oh, there's no way they can reach that peripherally when they're going from the center, but they do. I have seen pieces of chest wall in transbronchial biopsies. It's not uncommon actually. You see it every month or two, you'll see one. Skeletal muscle, adipose tissue, you're getting it from the tissue between the ribs. That's how far out they've gone with a transbronchial biopsy. So ideally you go to the pleura, you pull back a little, and then you get alveolated lung from there. Also, these are technical notes mostly for pulmonologists, that you open the forceps during inspiration, advance the forceps during exhalation, and then you get small pieces of tissue like you see on the left-hand side. See how small it is? So there's a 1 centimeter mark, and these are tiny millimeter-sized biopsy fragments. And I'm showing you small as opposed to a biopsy that's done by a surgeon is not small like this. You get bigger pieces of tissue. Those are called surgical lung biopsies. Surgical lung biopsies are biopsies done by a surgeon. It's different than when a cytologist says, go check on the surgical, they mean not cytology. And that's not the same as a surgical lung biopsy. So they're saying, let's do some cytohistocorrelation, go check on the surgical. That's not necessarily a surgical lung biopsy. Usually it's a transbronch or an endobronchial biopsy, okay? Surgical lung biopsy is done by a surgeon, and I'll show you a picture of that later. What I want to show you here is that when a transbronchial biopsy takes pieces of tissue, you see this picture on the right, this is an explant lung with UIP or IPF, and you see a transbronch will randomly sample pieces of lung here and there, and sometimes you'll hit the lesion, sometimes you won't. It's not like you have image guidance to show you exactly where you are, like a CT guided. So, although bronchoscopists don't like to say this, but this is essentially a blind procedure. You're putting the forceps in and hoping that something will show up. But the reality is that because it's a blind procedure, you won't always get the lesion. Sometimes you'll get pieces of normal lungs, sometimes you'll get non-specific fibrosis, chronic inflammation. It actually happens quite often that you get pieces like that. So you should know that during sign out, not to expect that every biopsy will have an answer. All right? This is the size of a transbronchial biopsy, and I call it making chicken soup out of chicken poop. You are taking extremely small things and trying to make a huge diagnosis of what is essentially maybe 1/10,000th of the entire lung, and you're getting one small piece of that, and you're supposed to tell the clinician what's going on. Now, I'll give you some examples of making chicken soup out of chicken poop. So where the biopsy actually did go into the lesion, and you made a diagnosis. So any one of the, I'd like a first year to try. Do you see the lung here? Yes. So this is interstitium, this is alveolar septa. That's the airspace, it's the space within the alveolus. And Naren, what did you say that was? Eosinophil. So what does that make the diagnosis? Eosinophilic pneumonia. So by definition, if the air spaces or the alveoli are filled with eosinophils, that's eosinophilic pneumonia by definition. And typically there are a few macrophages in there. Do you see that? Macrophages and lots of eosinophils. So this biopsy really went right into the lesion and got us a diagnosis. This is good because this is a steroid responsive disease, and there's a clinical implication to this diagnosis. All right, let's try somebody else. So not Naren, someone else. One of the first years. You've got lung here, right? So there is alveolar septa, airspace, and you see that at low magnification. Anyone? Is it normal?
There is a hyaline-like material.
Yes.
Amorphous material.
Amorphous material. What do you think it is?
Alveolar proteinaceous.
Yes. So not hyaline-like, but it is proteinaceous. Yes. And it fills up the air spaces, right? Look at the interstitium. It's all basically normal. There's nothing happening in the interstitium. Yet there's filling of the air spaces by this pink granular material. This is actually surfactant. And when you get that, this is by definition pulmonary alveolar proteinosis, PAP. That's one of the things you can diagnose with a transbronchial biopsy. So this saves the patient a larger procedure. It saves them from having a surgical lung biopsy and so forth. Also, this is one of the procedures where BAL can be diagnostic. We recently had a case like that. where if you wash out the alveoli with that fluid I was talking about, that fluid will actually show up in the jar as a turbid milky fluid, and you can see it on cytology. It's very gross. It almost looks like milk, that kind of fluid that comes out. So PAP is another example of a diagnostic transbronchial biopsy. Here's a CT scan that's showing bilateral ground glass infiltrates, meaning like hazy opacities. Anyone? What's going on here? First years? Where is the abnormality? The interstitium is mildly thick, but where is the main abnormality going on?
Alveoli.
In the lumen of the alveoli, right? Those are called air spaces. And what does it look like? Just describe it.
Frothy material.
Frothy material. So that's basically the diagnosis, right? What is it?
It is pneumocystis.
Pneumocystis pneumonia. So when pneumocystis pneumonia, when the bugs of pneumocystis accumulate in the lumens of the alveoli, they create this frothy appearance. And in fact, you can see these little dots here, the purple dots. Those are the organisms. And the froth is actually a very, very good indicator that you are dealing with pneumocystis. This is another classic transbronchial biopsy diagnosis. What stain is this, guys?
GMS.
What does that stand for?
Robotic methanamine silver.
Grocott methanamine silver. And that is a stain for what kind of organisms, Derek? Fungal organisms, that's correct. So pneumocystis, which in the old days was thought to be like a parasite, is now known to be a fungal organism. And this is, what kind of patients typically get it? Pneumocystis pneumonia? Immunocompromised. So HIV/AIDS would be the classic example, but many other settings. So these are pneumocystis organisms, and you can see the crescent shapes and helmet shapes on a GMS. Let's give you another. This is a little tougher. Let's try one of the third years. Anyone? What are you seeing here, guys? Are there second and fourth years here too? No, third year. Okay. Anyone?
Granulomatous inflammation.
Yeah, it's kind of vaguely granulomatous, isn't it? That's a very good eye actually, because it's not well formed. It's kind of loose, so it's good. But the key thing is to see there's these epithelial histiocytes, slightly squiggly looking elongated cells with like a shape like the sole of a shoe. So you've got vague, ill-formed granulomatous inflammation. This is also a transbronchial biopsy. Look what showed up on a Ziehl-Nielsen stain. So it's packed with organisms. This is the kind of picture you usually get with MAI or MAC organisms, just packed with large numbers of organisms there. You will also sometimes in a transbronchial biopsy, because you're going through the bronchial mucosa, you will also get pieces of bronchial mucosa in the biopsy sometimes. And you see up there, that's on top is the epithelium and the basement membrane, and the bottom has the similar kind of granulomatous infiltrate. Can you spot what's going on there? Anyone? Yes, there's acid-fast bacteria in there. So another diagnostic transbronchial biopsy. Can you tell from looking at it whether it's TB or non-tubercular? No, impossible. Can you, Brenna? Do you think you can?
We used to have some differential, long and slender.
Yes, and
I don't know if
is it enough to base therapy on? No. So there is actually one bug which is, somehow it's entered the literature, that Mycobacterium kansasii are longer and they're banded and so forth. But the vast majority of mycobacteria in the lung are not kansasii, right? It's either tuberculosis or non-tubercular. MAC is the most common one, and there's no way to tell them apart, just by morphology. So you need either cultures or you need PCR to be able to tell those two apart. All right. What is this, guys? Anyone? Granulomas. Are they in the interstitium or airspace? Yes. So on the left side, the long arrow points to a granuloma in the interstitium. The short arrow points to the airspace. On the right-hand side, the short arrow points to the airspace. The arrow points to the airspace. So the granulomas are in the interstitium. They are well-formed, correct? Large, well-formed granulomas. And there's a little bit of fibrosis around it, not much. So these are classic sarcoid granulomas. Another very common reason for clinicians to do transbronchial biopsies. All right, let's look at this one. Now, this is a difficult indication for transbronchial biopsy, interstitial lung disease. You see, some of these are relatively normal. It's low mag, so it's hard to see. But these ones are normal, but look at that one. See, there's a small focus of honeycomb change there and something going on in the interstitial. So here we actually have a diagnostic biopsy when it comes to interstitial lung disease. Now, do you see on the left-hand side there's some fibrosis in that piece? So that piece has a finding known as fibroblast foci, which are these little areas of fibroblast proliferation. And there's interstitial fibrosis, and there's a small focus of honeycomb change. I won't go into details, but because you'll learn this more when you do lung pathology, but just to say that this is a very difficult diagnosis to make on a small lung biopsy, on a transbronch. Usually these patients need a bigger surgical lung biopsy. So if you can make it on a transbronchial, you're saving the patient a bigger procedure. And anyone, what is the risk of getting a bigger procedure? Can you tell them? Anyone? Why shouldn't you get a surgical lung biopsy? What happens? Let's say you have an UIP, IPF, and you get a surgical lung biopsy. What is the risk? What's the risk from any surgery? Yeah, well, transbronchial biopsies also can cause pneumothorax. But anything else?
Fibrosis would increase.
Yeah, it actually can get exacerbated. So not just fibrosis, you get acute lung injury because of the surgery, and patients can die. There's a small risk of actual mortality from getting a biopsy. So just imagine you're going after a diagnosis and the patient dies. That's the worst outcome that can possibly happen. So there is a risk of exacerbation. Even if there's no mortality, there's risk of morbidity, and then all the usual things that come with surgery, right? Infection, bleeding, and all that stuff. So you want to try and avoid it as much as you can for the patient to have to go to the next level. So this, you can actually make a diagnosis of usual interstitial pneumonia or UIP on the basis of this biopsy. One of the classic things about that is that there is a very abnormal lung, like you see on the left, juxtaposed to a normal lung on the bottom right. So that patchwork kind of pattern is very characteristic of UIP. Here's a close-up of a fibroblast focus where you have fibroblast proliferation in the interstitial. All right, now this is another great example of a diagnostic transbronchial biopsy. So on the right side, you see ground glass opacity similar to what you saw in the other case, except there's some relatively lucent areas that's called air trapping or mosaic attenuation. And then there's basically ground glass on both sides. And on the transbronch, can anyone tell me what you see here? You're basically, this is the artery and this is the bronchiole. So you're close to the bronchiole. What are we seeing there? Third years? Yes, that's correct. Like here, right, Maria?
Mm-hmm.
Giant cell. And then what's in the background here? Lymphocytes. So it's not just in the bronchiolar mucosa, which is there, but it's also going into the interstitium here with a few giant cells. Anyone? What is this? HP. What does that mean? Hypersensitivity pneumonitis. So that's a big diagnosis to make, right? Just based on a small biopsy. But that's another thing you can diagnose. And one of the dictums is the closer the pathology is to the bronchus or the airways, the more likely you are to be able to make it with a transbronch, which is normal, right? If I told you that the pathology is right behind this door, you just have to grab it and get it. That would be more likely. So that's what happens with sarcoid, with hypersensitivity pneumonitis, with cancer that's in the lymphatics next to the bronchus. It's easy to grab it. If I told you the pathology is way over, in the next row, you would say, well, that's kind of hard to get. You can still get it if you pushed far enough, but it's harder to get. So this is an example of hypersensitivity pneumonitis. And again, you'll learn more about this when you come to your lung pathology rotation. And here's another very, very cool diagnosis to make by transbronch, not very common, but you see here on the left-hand side, there is a lesion here, but it sort of has irregular borders. See that? And this is an S100 stain, or could have been CD1A2. These are stains of Langerhans cells. And based on that, you can make a diagnosis of Langerhans cell histiocytosis in the lung, which is a smoking-related disease in lung pathology. So again, there are many things that can be diagnosed by transbronch. The only requirement is that they are actually in the lesion, and that's represented on the slide. If you don't get it, you have to say that's not diagnostic. Is that clear to everyone? We are going to switch to the lung cancer part, but any questions about non-neoplastic? Okay, can anybody tell me the 3 criteria for calling something a transbronch? Let's see. Who can? One of the first years I want. Small.
Non-needle shaped.
Not a needle shaped.
And it has alveoli.
As alveoli. All right. We taught you one thing before you leave this lecture. Okay, that's great. So I want you, all of you, when you come to the lung rotation, to be at least armed with that information. You know, and every time you see a biopsy, try to ask yourself, is this a transbronch or not? All right. Let's go to surgical lung biopsies, and the difference between that and transbronch we've already talked about. But here's a picture on the right side that shows the size of the specimen you get. You know, it's really a big chunk of tissue that you get either by opening the chest, so it's an open lung biopsy, or you can put in a scope, you know, and not actually open the chest, but grab a piece of tissue like that and bring it out. That's called video-assisted thoracoscopic surgery, or VATS. So VATS is another way to get a surgical lung biopsy, either open or VATS. And those pieces are much bigger, and of course the diagnosis rates are much higher because you're getting much more tissue in those. In a block, which one is the transbronch and which one is the surgical? Which one is transbronch? The one on the left, right? It's very small, and look at this, the size of the piece in a surgical lung biopsy. Alright, now we're going to do a couple of things on core needle, and then we'll move on to the cancer. Sorry, I forgot we had core needle biopsies too. So small and needle shaped, alright? And that's what you get, needle shaped pieces of tissue. So you should be able to just look at the slide and say, that's a core needle biopsy. And because it's a core needle biopsy, they are trying to biopsy a, what's that? I couldn't hear.
Peripherally located.
Peripherally located, what kind of lesion? So an interstitial lung disease wouldn't be biopsied with a nodule or a mass. That's what they're trying to biopsy. Almost always they're trying to biopsy a localized lesion. Yes, you're right, peripheral usually, but a nodule or a mass. So look at the power of that finding. You pick up a slide and you see that needle-shaped thing and you go, I know this patient has either a nodule or a mass, right? And what's the difference between nodule and mass? Anyone who's done? Yes, size, right? What is the size cutoff? 3. In lung, we are peculiar in that we use size as to describe the lesion. So less than 3 centimeters is a nodule, more than 3 centimeters is a mass. And if you don't use that on your lobectomies, I will hound you mercilessly. I'll send you emails, I'll make sure that you change it. So let's go to this. So you see that there's a lung nodule there. The arrow shows that on CT. So you can put a needle into that and get a thing like this. This is a core needle biopsy. What does the red arrow show? Anyone? What can you guess? It's all pink. Necrosis. And what do you think the yellow might? It's very difficult from this line, but it's the edge of this necrotic. Yeah, okay. I'll show you later. But this is a paper on core needle biopsies that was done by Dr. Dockstader. She's in the audience. When she was a resident, wrote a great paper on core needle biopsies that's very, very helpful in routine diagnostic practice. It's now 9 years ago, 2010. And this is one of the kinds of things that were mentioned in the paper, where you can make a specific diagnosis of a non-neoplastic lesion. Now remember, when you do a core needle biopsy of a lung nodule, you are mostly thinking this might be cancer, right? So most of the lesions that you get are cancers, but sometimes you get a non-cancer lesion. And the yellow arrow is actually granulomatous inflammation, small epithelial histiocytes. You were right, the red arrow is necrosis. So what does that make this? Necrotizing granuloma. And what do you see inside it? Yeast forms, right? This one is histoplasma, which is what you will see the most often here. Almost like you saw TB in India, you'll see here histoplasmosis. It's like the endemic baseline infection for this place. It's very common to see that on core needle biopsies in places that have a high histo. Here's another lesion very similar to that. There's a necrotic thing on the pink stuff is necrosis. The bluer stuff is cellular, but look what we have here. Anyone? What is this?
Still probably histo, but in the reticular endothelial systems are disseminated.
Yes, very good, very good. I'm very impressed. So this is, Ellie is not here, right? There is a difference between the histology in disseminated histoplasmosis, where you have no immune system, and the bugs just get into the macrophages and become big like this. This is the classic histology of disseminated histoplasmosis, which is the fatal form of the disease. And what I showed you in the previous slide was the histology of just nodule-forming histoplasma in the lung, those old, healed histoplasmosis in which the bugs are dead. You can see them on the GMS, but they never grow in cultures. This is very bad. This will grow in cultures, this will kill the patient, and rarely you will see this in lung biopsies as well. This one was in a core needle biopsy, also in one of Dr. Dockstader's papers. And then, what's going on here? Does anyone see something? This is a board question. You should know this.
They are budding.
Yes, why do you say blasto?
Broad-based.
Broad-based budding. And one thing very few people know is that, see this nuclear material that's inside is also a good clue that it's blastomycin. Third thing, what cells are around it? Neutrophils. So if you have a suppurative reaction, that's also a clue to blastomyces. And this core needle biopsy made the diagnosis. Alright, here's a needle going into the lesion, right? Transthoracic core needle biopsy. Got a piece of tissue like that. What do you see in there? That is a spherule, it's called. It's big. It's hard to tell without context, but that is a spherule, and there are endospores within it. Let's say this patient is from California. What are we getting at? Coccidioidomycosis. Another thing that's diagnosable with a core needle biopsy. Another core needle biopsy, the lesion is at left lower. See, that's the CT scan of the lesion, big mass. Anyone see anything here?
Invasive fungal.
Yes, these are invasive fungal. And why do you say that?
Because there's like a vessel that seems completely obliterated with hyphae or pseudo-hyphae camellate cell.
Very good. We should hire you on the lung pathology right now. Give you a job right now. Very good. Very good. Yeah. So that is invasive aspergillosis. Here's another picture with another specific diagnosis, although it's not a bug. Do you see this thing here branching like that? Anyone who's been on the lung service, do you know what this is? Organizing pneumonia. Plugs that branch in a serpiginous way, polyp-like plugs. Organizing pneumonia. Another diagnosis that can cause a lung nodule or mass, but actually is benign. And then, what is this icon? Oh yeah. Anyone? Nothing malignant, right? What's the pathology? What is the vast majority of this nodule like here?
Degenerated elastin fibers.
Yes, right, that's right. It's like solar elastosis like you get in the skin. The same kind of like fibroelastotic thing you get in the lung too. And that it's just a scar, right? It's a scar. But you get this typically at the apex of the lungs, and it can make a nodule-like lesion, and that's called because at the apex of the lung, it's called a pulmonary apical cap. It's like a cap on top of the lung. Pulmonary apical cap. Again, benign lesion, very good for the patient. You can also biopsy lymph nodes inside the lung that look like nodules. So benign intrapulmonary lymph node. And finally, you can also, you see this patient has multiple bilateral lung nodules. Do you see that on the CT? Small bilateral nodules. Clinicians are usually worried about fungal infection or disseminated malignancy, TB. But what do you have on the back? LCH, Langerhans cell histiocytosis. You've got lots of eosinophils and Langerhans cells, and the bottom right is actually the immunohistochemistry proving it. Here's another example with the small bilateral nodules. Do you see that? Like that one. Tiny millimeter-sized nodules, same differential. And again, you've got sheets of Langerhans cells on the bottom right and lots of eosinophils on the top left. Great news for the patient because it's not malignant. They stop smoking and they can be cured of this lesion. Alright, let's switch gears and talk about lung cancer. So for each of these, there's a question, and I'll have each one of you separate people answer that, okay? So we're going to just talk about how you approach basic questions in lung cancer therapy. Okay, Atsuko, I'll start with you.
Sure.
Alright. elderly woman with widespread Mets, so there's Mets all over the place, so stage 4 disease, lung mass, and we got a transbronchial biopsy and we found adenocarcinoma. How will this patient be treated?
First, we want to know the adenocarcinoma. Where is the primary?
Let's say lung.
Lung.
Yes.
So I want to see the EGFR is possible.
Yes. So she's touched on a very good point. Is first thing you want to know is, does it have any driver, right? And where did the drivers come from? Who tests that? Like EGFR, what's that? Who asks molecular pathology to test it? How do they know? We do it. So we initiate the therapy, the testing here. So for all adenocarcinoma diagnoses, we do reflex testing of molecular markers. So EGFR, ALK, KRAS, MET, RET, ROS, it just goes on and on. We do a big panel. So you're right, Atsuko, right? We need to know whether this thing has a driver. And if there's no driver, what else do we need to know, Atsuko? There's one more thing. Let's say all the drivers are negative. There's another kind of therapy that's new, and then PDL1. Very good, yes. So PDL1 is the other thing we need to know for these patients. If they don't have a if they have a driver, they get driver-directed therapy. If they don't have a driver, then PDL1 is the next thing. Because if their PDL1 is high, more than 50% for the first line, then they get immunotherapy, pembrolizumab. Whereas if they don't have PDL1, they go to, what's the last option? If you don't have PDL1, no driver, nothing, what do you get? Chemotherapy. And then you get standard chemotherapy, like we have had for the last 50 years. But the difference is, in the old days, everybody got chemotherapy. Now only this, kind of leftover group gets chemotherapy. Everybody else gets driver-directed or immunotherapy. All right. Let's go like this, okay? All right. So everybody knows that their turn is coming. All right, Naren. Elderly woman with widespread Mets and lung mass has a squamous cell carcinoma. Right? So we get an endobronch, we say, okay, keratinization, squamous cell. How do they treat now?
Resection.
What's that?
Resection.
Resection. With widespread metastasis.
Oh, widespread metastasis.
Right? So stage makes a difference, right? Yeah. You already know this is why. So resection won't be appropriate in this case. What can you do for this patient?
Radiation.
You could, if there's a big mass, you could radiate. Anything else? Chemotherapy. So in the old days, you would be giving chemotherapy, but in the new days, what do we have options? Do you want to test them for EGFR and all that? Not for squamous.
Okay.
So smokers typically get squamous, right? They don't have appreciable levels of driver mutations. Does everybody understand that? So we do not test squamous cell carcinoma for those drivers that we would have tested adenocarcinoma. Okay? So we do test one thing though. What do we test? PDL1. So we're back to, so the PDL1 is done for all these adeno and squamous, but the drivers are done only for adenocarcinoma. Is that clear to everybody, how we do that? So this patient would get PDL1 testing. If the PDL1 is high, they'll get immunotherapy. If the PDL1 is not high, then they might go back to standard chemotherapy. Clear to everyone? So it makes a big difference. What we're doing here, the diagnosis, the markers, and the PDL1 makes a huge difference to how patient is treated. Okay, let's go to next. Let's go. Okay. So elderly woman with widespread Mets and lung mass. So now we have an adenocarcinoma, widespread Mets, and ALK positive. How do you treat?
I don't know the exact name of the medication, but we have a driver.
We do have a driver. So we give driver-directed therapy, right? Does anyone know the name of the therapy? ALK positive? No? It's such a big thing. So in the old days, it used to be a drug called crizotinib. It's a big breakthrough in medicine in general, to have such a great driver like that. So in the old days, it used to be crizotinib. Just recently, it's changed to a drug called alectinib, which is now found to be better than crizotinib, especially for brain mets. So you're right, you give driver-directed therapy. Is everyone clear with that? And we test for ALK either by immunohistochemistry, we have an ultra-sensitive antibody, or we test by FISH. So either way, we initiate the testing protocol here. All right, Mina. So we're changing this scenario. Elderly man adenocarcinoma, 1.5 centimeter nodule, right? Less than 3 centimeters, nodule, not mass. Everything is negative. Nodes negative, PET negative, brain MR negative. So all they have is the nodule. How do you treat?
In this case, can we maybe operate it and remove it?
What operation do we do?
Um,
Just take out the nodule, or do you
no,
want
no,
the
some area?
Yes.
Lobectomy.
Lobectomy? Yes. So standard treatment for this is to resect with a lobectomy. Is that clear to everyone? So if the stage is low, if it's only in the lung, you take it out, and the standard operation is a lobectomy. And that's how it stops. And then everything depends on what we find in the lobectomy at that point. Then the subsequent thing goes on.
What about wedge
Yes.
resection?
Yes, that's a good question. So there are some situations in which a wedge resection would be appropriate. For example, patient cannot tolerate a lobectomy. They're emphysematous, they have bad lungs. Another is there are some forms of very low-grade adenocarcinoma, like adenocarcinoma in situ or minimally invasive adenocarcinoma, where radiologically you can tell just by the fact that it's ground glass and very small. In those cases, a wedge resection might be enough therapy, and you don't need to go to lobectomy. But the vast majority of cancers do need. So all squamous cells, all invasive adenocarcinomas need a lobectomy. That's the standard. Does that answer your question? Okay. So then, who's next? All right. So we'll change the situation. Now it is a man with adenocarcinoma, nodule. Same. It's actually the same person, but had their lobectomy. So the lobe has come out. It came to you. You found a 1.5 centimeter adenocarcinoma. Nodes were negative. Margins were negative. There was no visceral pleural invasion. And he's done. He's done. That's the right answer. So that's the great thing about these low stage tumors. Now, it's not that he is cured, right? Because these things can recur in the long run. Some of them will recur, actually many of them will recur. But for the current time, you don't need any therapy for a small lesion with no other bad signs. Now, if the nodes were positive, it would be different. If it were a 6 centimeter lesion, it would be different. But for a small node negative, visceral pleural invasion negative tumor, they're done for now. They can go home and then they'll get followed with serial CT. Is that clear? So this is the best case scenario for patients to have a low resectable lesion. Let's go like that. Kate, we'll come to start with you. All right, let's go to elderly man with a lung nodule, non-diagnostic biopsy. So we don't have a diagnosis prior to surgery. Then he goes to surgery. Surgeon brings you a wedge resection, brings it to you at frozen, and you say, frozen section shows adenocarcinoma. What is going to happen next? So at frozen, what will happen next? So you have an adenocarcinoma. The wedge has already been done, and the surgeon, you told the surgeon, here's an adenocarcinoma. What will he do? She do?
The wedge is not enough.
The wedge is not enough. So what do they need to do? Lobectomy. So they need to complete the procedure, right? That's why we call it a completion lobectomy. And that is one reason. So if you're the person who's doing the frozen, remember the initial wedge, the margin on that is not a true margin because the lobe is coming. You understand? So we ink it, but that ink is not, it doesn't matter because the lobe is coming after that. Now if they said, I'm not going to do a lobe because the patient can't tolerate it, that is the true margin. But usually they will complete the procedure and give you a lobe in a second procedure, and the margins on that are the true margins. Does everyone understand that? Yeah.
Could you talk a little bit about why the surgeon would ask for frozen on a
Yes.
lung mat?
Yeah, that's a good question. So in the surgeon's mind, they don't have a biopsy beforehand, right? So they're trying to think, am I doing a lobectomy for a benign lesion? So what they want to know is this malignant or not? So if it's malignant, they complete the lobe. If you tell them it's a granuloma, they stop. Right? So that is the major reason they are doing those procedures. Is to know, is it benign or malignant? Do I need to complete the procedure, do a big procedure, or just stop there?
So if the margin on this wedge is negative, do they complete the procedure or it's complete?
It's not, on the wedge, the margin isn't really a wedge. It is not really a margin because the lobe is coming. So let me explain to you like this. Let's say you got, this thing is the wedge, the cap of the bottle, okay? This is the bronchial margin connected to the rest of the body. Now they said, what is this lesion? You say adenocarcinoma. Then you say, okay, the whole bottle is coming out. What's the true margin? That's the margin. Is the edge of this the margin? No. So it doesn't matter. You inked it. You did a good job and inked it. But that's not the true margin. Does everyone understand that? Now let's say the surgeon says, I can't take the bottle because that's crucial for the patient to keep it. Now what's the margin? That's the margin now. So it does make a difference what the surgeon is going to do next. And in most cases, they are going to complete the lobe. I ask, when that kind of thing happens, and when I call it in, I say adenocarcinoma. Are you going to do a completion lobe? They go, yes, it's coming. I say, okay, this is no more margin. Everyone understands that? All right, how much time do we have? We have 13 more minutes. All right, who's next? Ahmed, I think we'll go to you. All right, we'll go like this.
I have a question.
Yes.
Would they do anything different if it was like colonic primary or a different primary?
Good question. Yes. So let's say if it was a met from the colon. In most cases, they would stop there. So they are trying in those cases to do a metastasectomy, not a completion lobectomy. Lobectomy is treatment for primary lung cancer, not for a met. Good question. Yes?
What if in a metastasectomy the margin is positive on the wedge?
Ideally, they should take more.
Okay.
So you want to, in a metastasectomy, especially with, like a solitary met, that actually has some therapeutic role too. It's not just diagnostic. So if you resect the solitary met, that gives some added life expectancy to the patient. So they want to get it out with a clean margin if they can. Now if somebody has, 20 mets to the lung, is going to take one out, make a big difference? Probably not. But with a solitary met, it does make a difference to get a clean margin. Great questions.
I have a question.
Yes.
This might be a little bit basic, but Salam and me got this case on
Yeah.
the prison section.
Mm-hmm.
So continuing with the bottle analogy.
Yes.
When the lobectomy comes out,
Yes.
do we have to again do a parenchymal margin?
Yes, good question. All right. So the bottle, now let's take this analogy further, okay? Here's the upper lobe and the rest of my body is the middle and lower lobe, right? So let's say this is the bronchial margin. With that is the vascular margin too. So you cut that and give a shave of this. So bronchial margin, vascular margin. But the bottle is actually connected to the rest of the lung too, right?
Yeah.
So that is the so-called parenchymal margin, where the lobe is connected to the rest of the... Now some people will argue that the parenchymal margin is not significant. And in fact, in our old institution that we never sampled the parenchymal margin. But here how we do it is we say that margin is significant too. So we want to know, is that margin involved? Does the tumor get to there? So this margin is not a margin anymore, right? That edge is not a margin. What is a margin is this. So you want to cut like that and ink one side of it so you know what happened at that edge. So there is really a parenchymal margin. Now just to complicate things a little bit, sometimes the surgeon will write on the form bronchial margin only. Then only do the bronchial margin. For some reason they don't want the others, that's fine. But typically when you get a lung lobectomy specimen, this bottle, right? You want bronchial margin, vascular margin, parenchymal margin. Does that answer it?
Yes.
Clear to everybody? Lobectomies have 3 margins. How about the pleura? Is that a margin? No. The pleura floats. There's no margin there. We used to ink it, but that's just it makes no sense. Because the pleura floats, it's in the chest cavity, it's not connected to anything. So that's not a margin. All right, this is a great discussion because it makes things clearer in terms of resections to everybody. All right, so who is next? Ahmed, did we do yours or no? All right. Let's go to the next one. Elderly man, 1.5 centimeter lung nodule, non-diagnostic biopsy, wedge resection. This time it's squamous cell carcinoma. What's the treatment? What should he do? Completion lobectomy, right? So the next thing you should remember, it doesn't matter whether it's adenocarcinoma or squamous at frozen section. Later it matters, but not at frozen. They just want to know malignant or not. You could say non-small cell carcinoma, that would be enough. You could say carcinoma. You could say malignant. They need to take it out, right? Just tell them it's malignant. All right, who's next? Ryan, ready? Let's do elderly man with 1.5 centimeter nodule, non-diagnostic biopsy, almost the same. Alright, so now he's done the lobectomy. He did the completion lobectomy. You said the bronchial margin is positive. So you said the edge of the bottle is positive for carcinoma. What happens next? What should? They should take more. That's the right answer. So they should take more of the bronchial lesions. Sometimes that means they have to take the whole lung because that's the way the anatomy goes. So they have to do a pneumonectomy. So this is a big call, big deal. You're telling them take the entire lung out. It makes a big difference. So call somebody. Make sure a lung pathologist looks at that, or you're absolutely sure that it's there. Do you understand? It's how big of a deal that is. Sometimes they won't do it because it's such a big procedure. They'll say, fine, we can't do anything. All right, Celeste, we go to next one. 3.5 centimeter lung mass, endobronchial biopsy, squamous cell carcinoma. You got a lobectomy. You say, now let's take it out of frozen section. Okay, we're not at frozen anymore. You've got it for permanent section, and you said one peribronchial lymph node has squamous cell carcinoma. Do they need treatment or not treatment? The lobe is already done.
They need treatment.
They need treatment. That's the right answer. Even one lobe involved gets them chemotherapy or more advanced therapy. Even one lymph node. It's such a big deal. But if the lymph node was not involved and it was a small lesion, they might be done. Therapy might be over. Is that clear to everyone? How important lymph node mets are in this situation? Alright, Ashley, let's do the next situation. Lung mass, adenocarcinoma. Surgeon's done a lobectomy. You've got the lobe. You're the resident doing it. You go. 4R is positive. 7 is positive. So lymph nodes are positive for adenocarcinoma. What treatment do they get? Systemic therapy. So what information do you want to know for that?
Well, if there's a driver.
Is there a driver? Very good. So we remember. Do you understand now how histology matters there? If it was squamous, you wouldn't ask for a driver. But now it's adeno. You say, what's the driver? What's the PDL1? And you want to go down that route. Very good, guys. Alright, Meredith, let's go to the next one. Now you have a woman with widespread mets and a lung primary. You do a transbronchial biopsy and that shows adenocarcinoma. All the drivers are negative. What do you want to know next?
What's her PD-L1 status?
What's the PD-L1 status? More than 50%? Immunotherapy. Less, it might go to chemotherapy. Very good. Alright, Miriam. 45-year-old man, lung nodule, endobronchial biopsy and brushings. Your diagnosis is carcinoid tumor. What's the appropriate therapy for this?
Surgical resection.
Surgical resection. Usually lobectomy. Right? Even though a carcinoid is a very low-grade lesion, but they like to take it out. Alright, Sindhu, do we have more? Yeah. Elderly smoker with bulky hyaluronopathy, SIADH, and lung mass. You got a transbronch, you said small cell carcinoma. How do they treat? Can you resect? Systemic therapy. So you need chemotherapy, now you can even add immunotherapy on top of that. That's the latest thing. But yes, this patient gets a totally different, goes down a completely different flowchart. Doesn't get markers, doesn't get PDL1, none of that. It goes straight to the chemotherapy line. So you see how histology, what I'm trying to show you is how important the things we do for therapeutic decisions, how important they are. Alright, so we're going to end it here, and I want one more time, the last thing that you guys learned from this lecture. What kind of biopsy is this, everybody? Transbronchial. Okay, thank you for coming.